My name is Sudipto Mukherjee. I am the Director of Rare Cancers and Blood Diseases at the Cleveland Clinic. Uh, I trained, uh, I did my fellowship at the Cleveland Clinic Taussig Cancer Institute, then stayed back here as a staff. I do have a master's in public health and epidemiology and biostats and a PhD in molecular biology. My clinical and research interests are myeloid malignancies such as acute myeloid leukemia and MDS, and a host of other rare neoplastic and non-neoplastic hematologic diseases. So this was actually a retrospective cohort study. The rationale for doing this study was, if you look at the only two FDA-approved drugs for the treatment of myelodysplastic syndromes, they were approved in 2004 and 2006 for azacitidine and decitabine, respectively. We are now in 2025, so almost 20 years have gone by. And if you look at several analyses done, population level analysis done by other investigators across the country, what we see is the improvement in survival of these newly diagnosed high risk MDS patients being treated with these two hypomethylating agents, azacitidine and decitabine, has really not improved over the past 20 years, even though we have FDA approved drugs from 20 years ago. This is, and at the very best, depending upon the study, even when we see a benefit, it has been very modest. Certainly not close to what was shown and demonstrated in the landmark trial AZA-001 with azacitidine. So that kind of triggered our curiosity as to why is the fact that we have these drugs, we just have two of these drugs, and why are we not seeing any survival benefit in these patients? This is a critical question because we know that the only therapeutic modality with a curative potential in MDS is an allogenic bone marrow transplant. But unfortunately, majority of the MDS patients who happen to be above the age of 70 years in the US, they have so many other significant comorbidities that they do not turn out to be eligible candidates for a bone marrow transplant. So for these patients, the only options are these hypomethylating agents. And we wanted to know where were we falling short in using these drugs, because the analysis from other investigators showed very little to modest survival benefit over these past 20 years since these drugs have been around. So that was the rationale for the study. And we used the Medicare claims files. So the Medicare claims files actually includes all kinds of information, including the diagnosis, their comorbidities, the type of treatments they have been on, for how long they have been on, how frequently were they getting it, and several intervening medical events if they happened over time. And we use the Medicare claims files because the Medicare includes population above the age of 65 years. And that is actually the demographic cohort where we see most of the MDS in the US. So it really allowed us to comprehensively capture as uh, as thoroughly as possible the MDS population in the US. And secondly, we were able to link this database with several other things, particularly to socioeconomic variables. So we're able to collect county level characteristics, such as, you know, how many people are below the federal poverty level, what is the educational attainment, or how many got the high school diploma education at least. Third, how many, uh, what is the population density of these places, the rural urban continuum, and finally, the concentration of providers and specialty providers who provide care for these patients. So we were able to tie up the clinical variables with the demographic characteristics and socioeconomic variables at the county level to try to get a best assessment of what are the factors that may or may not be explaining uh, how these patients are getting treated and where are we falling short. There are actually two key findings that came out from our study. One was uh, somewhat surprising, but somewhat not surprising. What the one of the things that we found out was typically in any cohort of newly diagnosed MDS patients, the high risk patients for which the hypomethylating agents are indicated, they happen to be 30 to 40% of all newly diagnosed MDS patients. You would think, based on the approval status of these drugs and the indications, all these newly diagnosed patients, or most of them, should be on HMA. But we found that only 16% of the newly diagnosed MDS patients received HMA. The number should have been closer to 30 or 40. So a lot less people who have the high risk newly diagnosed MDS and for whom the HMA are being indicated are being treated. And that is really puzzling. And this data was not really shocking because other investigators too have pointed out using different data sets that typically only 14 to 18% of the newly diagnosed high MDS patients ever get HMA, knowing fully well that the number of high risk MDS patients among the newly diagnosed MDS patients is as high as 30 to 40%. So we found underutilization of HMA in newly diagnosed MDS patients. Second, we found there were age, sex, and race related disparities in who got HMA and who did not. What we found out was in the younger cohort, which is defined as patients between the age of 65 to 74 years, whites compared to any other ethnicities and uh, uh, were more likely to receive HMA if they had newly diagnosed high risk MDS. Females, blacks, and age groups beyond 74 years of age were less likely to receive HMA. This was kind of curious because while uh, whites are more likely to receive treatment and have better outcomes is not a surprising finding and unique to this condition because it has been seen in other cancer conditions too. But the females was a little bit surprising because if you look at the prevalence of MDS in the MDS population, the split between males and females is roughly 50 to 50 and 50. The second important finding that we found was the way MDS patients are being treated with HMAs is very, very different from the recommended treatment guidelines. And we don't really know all the reasons for that. This study was not geared to answer those questions. You have to remember that MDS is mostly diagnosed and treated in communities. So these findings reflect the treatment practices and patterns being uh, observed or done in the communities, not in major academic centers or university hospitals or centers of excellence. And what we found is, according to the recommended treatment guideline, if somebody is started on an HMA for a newly diagnosed high-risk MDS, they need to receive at least 4 to 6 treatment cycles to see the full benefit of the treatment. You really cannot make a case of whether the treatment worked or failed before that. But what we found out was in our cohort of MDS patients, which reflects the MDS uh, practices throughout the country, uh, almost 50%. So I kind of look at it as a rule of 50. So almost 50% did not even complete the recommended duration of treatment. So that itself is a problem. If you did not get the right treatment for the right amount of time, you will not see the results that you're expecting. Second of all is this treatment is very unique in the sense that the HMAs are given in treatment cycles, and each cycle is 28 days. And for azacitidine, you need to get the treatment for the first 7 days in a row, for decitabine, 5 days in a row. And what we found in our study is in patients who were started on these treatments, almost 50% of them did not even receive a completed treatment cycle, meaning did not even get more than half of the required number of doses in a treatment cycle. So it goes back to the point that three things. Uh, Far fewer patients are getting HMA, even though it is indicated for the high risk newly diagnosed MDS. It's unclear why the younger white males are the preferred eligible candidates for HMA use, and why we see underutilization of HMA in females and blacks and other ethnicities. And third, the patients are not getting the treatment for in the right way or for the right duration of treatment. So I think these are a combination of factors that potentially explain why we may not have seen the anticipated survival benefits in these patients with these drugs that were approved almost 2 decades ago.